On behalf of the Twilight investigators, it is my pleasure to present to you the analysis on diabetic patients enrolled in the Twilight study. As already mentioned before, the Twilight trial was funded with an investigator-initiated grant from AstraZeneca to Mount Sinai, which was also the coordinating center of the trial. These are my disclosures. My disclosures mostly relate to makers of antiplatelet therapies, which include AstraZeneca. So as a way of background, we know that dual antiplatelet therapy with aspirin and a P2Y12 inhibitor is the standard of care for the prevention of thrombotic complications in patients undergoing PCI. However, this does occur at the expense of increased bleeding, which increases with a prolonged exposure to a dual antiplatelet therapy. And overall, these observations underscore the need to identify antithrombotic regimens that can reduce the risk of bleeding while maintaining efficacy. And amongst these, the use of a P2Y12 inhibitor monotherapy strategy after a brief period of that has emerged as a very promising one. And this was also shown in the Twilight trial, showing clearly that among high-risk PCI patients after 3 months of DAP, ticagrelor monotherapy reduced bleeding without increasing harm. So after these very exciting results from the Twilight trial, it obviously becomes of interest understanding if this antithrombotic strategy remains effective in patient cohorts of particularly high risk, such as patients with diabetes. Now, we know that patients with diabetes are at high risk for both ischemic and bleeding complications, and this is due to a number of reasons which characterize this high-risk patient population. And the topic becomes of clinical relevance, given the increase in the prevalence of diabetes worldwide. So the objective of this analysis was a pre-specified analysis to specifically evaluate the safety and efficacy of a ticagrelor monotherapy strategy versus standard dual antiplatelet therapy in patients with diabetes enrolled in the Twilight trial. As already mentioned, this was a randomized, double-blind, placebo-controlled study. And here you see the outline. All patients after their run-in phase of 3 months of dual antiplatelet therapy, where they had to be event-free and compliant to treatment, they were randomized, and from this point on, randomized to 12 months of treatment of ticagrelor plus aspirin versus ticagrelor plus a placebo. We already heard that patients to be enrolled in the trial needed to have at least one clinical and one angiographic high-risk criteria. And amongst the clinical criteria, diabetes actually represented one of them, and this actually allowed for our population to be enriched with patients with diabetic status. And again, they had to also have one high-risk angiographic criteria. As a reminder, the key exclusion criteria were presence of STEMI, salvage PCI, need for chronic oral anticoagulation, prior stroke, and planned coronary revascularization. The target population were patients with diabetes enrolled in the trial. In line with the primary trial, the primary endpoint was BARC 2, 3, or 5 bleeding between 0 to 12 months after randomization. And the key secondary endpoint was all-cause death, non-fatal MI, or stroke between 0 and 12 months after randomization. Our analytical approach includes a survival analysis for both the primary and secondary endpoints using a Kaplan-Meier method with hazard ratios and 95% confidence intervals generated using a Cox regression. The analysis of bleeding was using the intention to treat cohort, while ischemic outcomes, the per protocol cohort, and treatment effects were estimated according to the presence of diabetes with formal interaction testing to assess for effect modification. And we also conducted a series of exploratory analysis according to clinical presentation, type of glucose lowering treatment, and we also did an analysis of net adverse clinical events. Here you see the outline of the trial. Over 9,000 patients enrolled in the study, with 7,000 patients ultimately randomized. Key criteria for not being randomized was non-adherence, with around 37% of the patients being diabetic. There were obviously clear difference between patients with and without diabetes, with most patients with diabetes coming from North America. of non-white race, and clearly with having many more cardiovascular risk factors, prior revascularization, and multivessel disease compared to non-diabetics. In the cohort of patients with diabetes, which were equally distributed between the ticagrelor plus placebo and ticagrelor plus aspirin arm, and the 2,620 patients, we had a little bit more than a quarter of patients who were insulin treated diabetics. I would also like to highlight that adherence rates to ticagrelor and adherence rates to the blinded study drug were similar, were overall very similar. Here you see the baseline characteristics of the study. We had that mean age was close to 65 with a high prevalence of chronic kidney disease, anemia, with 61% of patients who had an ACS presentation and 30% of patients with a prior MI. This is overall very high-risk patient population where multivessel disease was present in almost 70% of patients, and overall complex anatomy with total lesion length close to 40 millimeters. I will now present the data on the primary endpoint, the BARC2, 3, or 5 bleeding. You can see that in the ticagrelor plus aspirin arm, this was 6.7%, and in the ticagrelor plus placebo arm, this was 4.5%, equating to a 2.2% absolute reduction and a hazard ratio of 0.65 and a p-value of 0.01. I will highlight in this slide the comparative data of bleeding with and without diabetes. As you can see here, the data on the primary endpoint, where the interaction p-value was 0.23, supporting consistency in the findings between the diabetic and non-diabetic cohorts. When it comes to other bleeding definitions of note, also BARC3 or 5 bleeding also significantly reduced, and there was consistency in the findings with all other definitions of bleeding. Yes, there was a positive interaction of 0.03, which should be considered as nominal for gusto moderate severe, given that this was a secondary endpoint and with very low event rates. I will now show the ischemic events of death, MI, or stroke, which was 5.9% in the ticagrelor plus aspirin arm, and this was 4.6% in the ticagrelor plus placebo arm, and with a hazard ratio of 0.77. I will now show the data, comparative data of patients with and without diabetes. And you can see there was overall higher event rates as expected in patients with diabetes, but overall very consistent findings. There was an interaction p-value, which was nominal at 0.05, but this needs to be considered in the context of a secondary endpoint. But what I would also like to highlight, which is particularly important with regards to the safety of a ticagrelor monotherapy strategy, that the vast majority of ischemic events, as you can see here, were clearly lower than with the ticagrelor monotherapy strategy compared to ticagrelor plus aspirin without any significant interaction. We also conducted an exploratory analysis. This was not pre-specified, of net adverse clinical events in which we considered BARC3 or 5 bleeding, therefore the most severe bleedings, death, MI, or stroke. This was 8.7% in the ticagrelor plus aspirin arm and 5.4% in the ticagrelor plus placebo arm, equating to a number needed to treat of 30 for net adverse clinical events. We also looked at outcomes according to clinical presentation of ACS versus stable. As you can see, consistent findings for the bleeding and ischemic events. And this was also very similar when looking at management of diabetes according to the use or not of insulin therapy, consistent effects. There are some limitations to this analysis. Although this was pre-specified, randomization was not stratified according to diabetic status, and we did not account for multiplicity, therefore increasing the chance for a type 1 error. Diabetic status was based upon physician diagnosis. We did not do any type of biomarker. Our findings cannot be generalized to patients treated with other oral P2Y12 inhibitors, in particular clopidogrel. This could be a topic of discussion. We did not include STEMI, so we cannot extrapolate our results to this cohort. And there was a lack of power to detect differences in the risk of important yet rare clinical events such as stent thrombosis and stroke. Therefore, in conclusions, compared with ticagrelor plus aspirin, the effect of ticagrelor monotherapy in reducing the risk of clinically relevant bleeding without any increase in ischemic events was consistent among patients with or without diabetes undergoing PCI. And overall, these findings support such a bleeding avoidance strategy, which can be implemented without any signals for harm, even in high-risk patients such as those with diabetes. I would like to thank all the country leaders, investigators, coordinators, and study participants who really made the Twilight trial possible. And the data is now available online in the Journal of the American College of Cardiology. Thank you very much for your attention.
Great, and congratulations. Dr. Thomas Holland, would you like to lead off with some comments or questions?
Congratulations, Dominic. That's just really an outstanding presentation, and again, really contributing to the literature on this issue. I think that with the findings being so dramatic, I guess the question I have for you is, while I understand that this is a subgroup analysis, so the interaction p-value is just somewhat nominal, how could you explain or give some insight into why, if anything, there was perhaps more of a benefit in the diabetic patients from the ischemic endpoint?
Yeah, it's a great point, and I think this ultimately derives from the potential harm that derives from bleeding. What we did notice in the trial, although there was consistency in the findings, when we look at particularly at the bad bleeds, the BARC 3 or 5 bleedings, there was a clear difference, and I think this all relates to the safety profile of aspirin or enteric-coated aspirin in patients with diabetes. There is literature suggesting that patients with diabetes may be more vulnerable to bleeding induced by enteric-coated aspirin, mostly attributed to integrity of the gastrointestinal mucosa derived by a vascular disease. So these patients are bleeding more and having big bleeds. We know that there's a clear link with ischemic events. So that's my interpretation to the study findings.
Yeah, that makes sense. I guess that's always been the question is, when you're getting the bleeding, are you stopping all the antiplatelets and having a higher ischemic risk?
Absolutely, absolutely.
Dr. Bott?
So first of all, I'd say to Dr. Angelillo, great presentation, very important study. Many of us were wondering whether the overall Twilight results would hold up in this important subgroup. And it's reassuring to see that within your study, those with diabetes, in fact, did have higher ischemic event rates. So that gives a lot of legitimacy to the analysis. I guess my question for you would be, how would you reconcile these results, say, with the Themis results, where that suggested that longer-term therapy in patients with diabetes with aspirin plus ticagrelor would be warranted? Do you think one could extrapolate from your study and say maybe protracted ticagrelor beyond this 12 to 15-month period might in fact be in order in patients with diabetes, in particular those with ACS or PCI or both?
Absolutely. I think that there's a nice link between our analysis and the Themis trial, with the understanding that in Themis there was the adjunctive use of aspirin. But it does speak to some specific benefits of ticagrelor in patients with diabetes. We've seen very consistently, not just in Themis, but also if you look at the diabetic analysis that you led, Deepak, from the Pegasus trial, where there was a mortality benefit. There's something specific related to ticagrelor in patients with diabetes. One of these could be related to the twice daily administration of the drug. As we know, patients with diabetes do have higher platelet turnover rates. Therefore, having a twice daily drug, which has been suggested also for aspirin, and there are pharmacodynamic studies to this extent, but we don't have clinical studies which we do have with ticagrelor. So I think there's something very specific there. Obviously, I would like to see in a Themis trial, which is the 60 milligram BID without aspirin, but definitely these data together with Themis leave open avenues for research on this specific topic of a ticagrelor 60 milligram BID without aspirin.
Yeah, in fact, one initial design of Themis had an arm without aspirin, but the regulatory agencies insisted that there be concomitant aspirin. Well, congratulations.
Thank you.
just wanted to say, I think it's also tremendous that in this time of epidemic, Jack has managed to publish both Twilight Diabetes and Twilight Complex simultaneously. And I'll put a plug in for a very nice accompanying perspective by Professor Patrick Steroiz that puts both these trials in perspective in the larger clinical context.
Thank you, Deepak. Dominic, I know we're tight on time, but perhaps if I could just ask one last quick question. It seems by and large that people have become more and more accustomed to dropping aspirin in the context of triple therapy, but perhaps a little bit slower to do so for patients who are just on dual antiplatelet therapy. And for somebody like yourself who spent a lot of time thinking about clopidogrel response variability, you certainly alluded to this a little bit in your presentation, but would you caution people against using clopidogrel as monotherapy if they are going to take a strategy of dropping aspirin?
Absolutely. And in particular, in patients with diabetes or high-risk patients in general. I know we do have some data from our Asian colleagues that did the study with patients on clopidogrel, but let's keep in mind that these were low-risk patients compared to those enrolled in Twilight. When we speak about specifically patients with diabetes, there's a clear association with impaired response to clopidogrel in diabetic subjects, which is mostly related to impaired metabolism of clopidogrel. We know that the exposure of the active metabolite in patients with diabetes is approximately 30 to 40% lower in patients with diabetes. So definitely, if you're going to go with a monotherapy strategy, in particular in patients with diabetes, this should not imply the use of clopidogrel.
Great. Well, thank you again, and congratulations today to all of our presenters, and thank you to our panelists. And certainly we're thinking of all the healthcare workers right now who are on the front lines, and sending our thoughts and prayers. So thank you again, and this will conclude the session.